Thank you very much for the opportunity and good evening from my part of the world. So I had the privilege of training under various mentors and thought it might be of interest to you to share with you what my professors taught me about radial polydactyly. I have nothing to disclose. So I spent half of 2014 at the Texas Scottish Rite Hospital for Children in Dallas, Texas, with Dr. Mary Beth Izaki. I don't like dogma was one of the few things that she said to me, and dogma she did not like. In discussing radial polydactyly, you cannot escape from Harry Wassell's classification. After looking over 70 patients of Dr. Flatt, his mentor, Wassell published this 7-part classification in 1969, and he did not include Flatt's name in his paper. Flatt later on made a significant comment on Wassell's classification in the 2nd edition of his book, The Care of Congenital Hand Anomalies. He said, I have removed the 7th group representing the triphalangeal thumb. In the preceding sentence, Dr. Flatt refers to what is known as the geneticist classification. Samia Tantami and Victor McCusick, both geneticists, classified radial polydactyly into 4 types. Geneticist type 1 is that which was expanded on by Wassell. They considered the opposable triphalangeal thumb as type 2, and this would include Wassell type 7 and the case series that was expanded upon by Dr. Wood. Geneticist type 3 are the non-opposable triphalangeal thumbs, or the 5-fingered hand, and then type 4, the syn polydactyles. Back to Dr. Flatt. So he said, in view of present knowledge, referring to the geneticists, McCusick and Tantami, I have removed the 7th group representing the triphalangeal thumb. By doing this, the incidence of the 6 type changes and type 4 becomes even more common. Unfortunately, as history would have it, the damage was already done. Right about the time of my fellowship, there was an increasing move in the United States to use Flatt's name in describing types 1 to 6. Undoing the damage required using the same vehicle that caused it through publications. So it became very trendy to mention both Wassell and Flatt in the same sentence, if not the same paragraph. So I learned that I must give proper attribution to co-authors and mentors. I spent many years under the tutelage of Professor Teo Lam Chuan in Singapore General Hospital, as well as the KK Women's and Children's Hospital. When I was the registrar, he told me that you must get married while you are still in love. So I proposed to my then girlfriend within a year of him saying that. In my training years, I read that osteotomies are performed to realign the skeleton in thumb duplication, and K-wires are often used to maintain the alignment. However, I never saw Professor Teo use one. Not that he had never used one before, but when he did, he tells me that the parents always looked unhappy and the children always cried when the wires were removed. I can show you some magic, was what he told me. You can stitch the bone, and this was how he went about doing that. This child has a type 4 duplication, and an oblique wedge osteotomy was performed to reduce the metacarpal head as well as realign the skeleton. The periosteal sleeve on the ulnar cortex was maintained for stability. Next, a hypodermic needle was used to create bone tunnels in the cortex, and then a set of 3 sutures were passed through these tunnels, either PDS 4.0 or Vicro 5.0. The bones were then sutured together using the 3 sets of sutures, 2 placed on the dorsal cortices and 1 on the volar cortex. The sutures were then tied, and then the radial collateral ligament was repaired. Post-operatively, the thumbs were just placed in a soft, bulky dressing. Post-operative X-rays performed at 1 and 2 weeks confirmed that the construct was stable and union was achieved by 6 weeks. Professor Teo did the very brave thing by starting off with Vicro 5.0. Vicro 5.0 has very good knotting properties, and if you look at this graph of the tensile strength of Vicro, it starts off with about 200 newtons before it deteriorates. However, it holds long enough for callus to form. However, I chickened out. I conferred with literature and found that Tonkin and Abid had shared their experience of using PDS-40 in suturing phalanges in the Bilhao-Croquet procedure. So I switched to using PDS-40. Now, PDS has a slightly weaker tensile strength of 150 newtons, but it's kept constant over a 6-week period before it deteriorates. So I learned from Professor Chew that you can stitch the bone. I spent 2013 with Professor Michael Tonkin at the Royal North Shore Hospital in Sydney, Australia. He taught me that as surgeons, that we all had our own preferences, but that our preferences must be based on principle. The Bilhao-Croquet procedure takes longitudinal elements from each duplicate and then combines them. But as with most surgical procedures, a picture tells 1,000 words. So you will find these line diagrams such as these appearing in papers and textbooks. And the 1,000 words the pictures do not tell you is the difficulty that is taken in order to match the congruency of either the metacarpophalangeal joint or the interphalangeal joint. So take this example of a child undergoing the Bilhao-Croquet procedure. Longitudinal osteotomies are made in the proximal phalanges. The central components are discarded and then the outer components are collapsed. But observe what happens to the proximal corners, which are marked by the dots. So when they're brought together, these corners create a ridge which impinge on the metacarpal head. Professor Tonkin did point this out in his papers, and he offers his solutions. So he says if a surface is incongruous, this may be sculpted into a satisfactory shape, or a beaver blade. The cartilage may be trimmed with a beaver blade so that the joint articulation can be as congruous as possible. So he taught me, like a Renaissance sculptor, you must carve away at the joint. So in the full description of his technique, Professor Tonkin observes that the phalanges may not collapse evenly, but meet either at the tip or base. The breadth of the metacarpal head he narrows by excising 2 triangles. And then once the soft tissues are decompressed, the phalanges can be opposed along the entire length. This is where carving away at the cartilage occurs. And then what results is a work of art. So I learned from Professor Tonkin that reconstructing the thumb is in fact a work of art. So these are some of the things that I learned in my formative years, and these 3 professors have influenced me very greatly. And I thought I'd share with you the little that I've learned from them. So I'd like to invite everyone to Singapore in 2023. We are hosting the Asia Pacific meeting, and I'd like for all of you to come. And hopefully COVID would be over by then.
Here we are. So, Dan, are you there? Are you?
I am here. Can you hear me?
Yep,
Yes,
we've got you.
Excellent, excellent. All right, thank you, Darryl. That was great. All right, so I had a few questions. You know, it's really interesting, by the way, as a comment, just the value of travel and the value of seeing other people's perspectives. And I think that's one of the great parts of this, or one of the of this type of lecture series, that you're getting really a global perspective. And so thank you, Darryl, for really highlighting the value of visiting other people, which I think not only does it create lifelong friendships, but and also resources that you can then call upon when you're stuck. But it's just, you learn so much. So I have a couple questions, and let me see what's going on in the chat first. I don't see anything on the chat, so I'll ask you some questions. Right, so similarly to you, we have gone to using PDS suture whenever we repair the ligaments, but we have not been using it as a bony fixation, which is really intriguing. And certainly, I think you can get monocryl certainly absorbs too rapidly. Vicryl also absorbs too rapidly, and it's interesting that you've also gone to PDS, which is what we've been using. I don't know if you have any comments on using non-absorbables. Is that something that people should go away from? My feeling is yes, but if you could comment on that.
I'm not sure about ligament repair. I still repair the ligament with Ethibond, if not Ticron, which are non-absorbable. There is a comment from tendon repair work where you would still aim to use non-absorbable sutures for the core repairs, because the scar that forms is never as strong as the normal tissue. I think for pediatrics, we can change the considerations a little bit with using absorbable sutures. People hate to have implants in their body for life, and that's where metallic implants are moving in terms of having magnesium implants in. But I think that for bone, that paper that I shared, which shows the tensile strength deteriorating over time, PDS is a great a tool to use. The reason why I still stick to the non-absorbables for the ligaments is because of the knotting properties. If I don't get the ligament in nicely and I don't get a good bite of the periosteum, then my worry is that the ligament might fall apart if the knot unravels. Whereas when I'm using PDS for bone, that goes through a bone tunnel, so it's less likely that unraveling happens, because I can catch the knot right where it emerges from the bone tunnel. So there's a little corner against which the knot can form tightly.
That's an interesting point. Other questions I had, you talked about carving the cartilage, and I've been reluctant to do to really carve the cartilage on anything that's going to become a contacting articular surface. My concern has always been the lamina splendens, and if you remove the top of the cartilage, you basically expose the rest of the cartilage to long-term wear. Have you seen this being a problem, or am I worrying unnecessarily?
Probably haven't had long enough follow-up with my patients. I've just been 5 years since I've come back, 6 years since I've come back from my travels. I don't see Professor Tonkin reporting this as a problem, but then again, I'm not sure how many of us actually do follow-up x-rays at 10 and 20 years with the children. So that this talk also juxtaposes the two problems the two different opinions where the joint is concerned. So Professor Chew designed the oblique wedge osteotomy in order to preserve the articulation between the first metacarpal hip and the proximal phalanx base, because he opined that if you keep the native joints intact, then the child would get better motion at the end of the day, instead of having to bully the joint surfaces into congruency. When you sculpt the joint with the beaver blade, there is of course a risk, I think, of removing too much, which is why it becomes an art. But I think Professor Tonkin is pretty proud of his results that he's getting out of the kids whom he has needed to do this. And he only talks about this when you have to combine the joints in the Bilhao procedure. Does anyone have a way out of it, or a good way out of it when the joint surfaces do not match in combining?
I certainly don't have a good way out of it, but I think the consequence with these kids is, or the common experience in my hands certainly, is that their range of motion is pretty restricted anyway. So I'm not sure we're dealing with where we're leaving them with normal joints. I personally, particularly at the interphalangeal joint, I don't see a lot of motion. I think the whole joint's pretty hypoplastic. It's the extrinsic tendons are, deficient in pulleys often, and so maybe that's why we get away with it. And as long as it's straight and of reasonable size, we're sort of kidding ourselves a little bit, perhaps. But You do see, we have seen people recently. I think we've had somebody present in this series showing the most amazing results for a Billhale procedure combination surgery. So maybe it's just me who can't do the operation properly.
Well, when I do it, I'm resigned to stiff joints. Yeah, MP and IP joints. Yeah.
Well, the other issue I think that is talked about somewhat, but I think it's the major problem is not so much the joint, which obviously has issues, but lining up the physes correctly. I find that the phalanges are not exactly of the same length most of the time, and if your physes are just off, you've basically created a pretty significant Salter-Harris fracture, and you have a high risk of a bar. And I certainly had that happen.
Yeah, sorry, Darryl, go ahead.
No, I agree. Not every duplicate would have equal length phalanges. I think it's a little bit more forgiving for the distal phalanx because the height of the distal phalanx under the nail plate doesn't matter. It's all about the proximal phalanx. In order to shorten the length of one phalanx, you can do a transverse osteotomy in order to shorten it just by a millimeter or two. But sometimes when the duplicates are really very small, it's very hard to visualize the exact level of the physes. I've encountered cases where the thickness of the physis is different in each phalanx. I'm not sure whether that's your experience as well, and matching them, just a little slip of the K-wire or the suture when you put it through makes all the difference.
Yeah, I think in my priority has been aligning the physis, right? And it's not like I've done many of these, and they're extraordinarily difficult. But I think, I think our priority should be getting that. So, because sometimes the distance between the joint and the physis is different.
Yes.
Exactly what you're saying. And so I think our priority maybe should be getting that physis intact, especially in a young child. I think the joint will accommodate and remodel over time.
Darryl.
Yes, Dr. Cheska.
Yes, every year I try to do a below cloquet procedure. I become brave. I do one and I see the results and I say never again. And every year I do the same. I never get a good result.
Yeah.
It's just because
you have to wait long enough until you wait long enough until you forgot how bad your last one was.
I'm not sure whether the part of the solution is in waiting for the duplicate to be large enough. I think most of us try to reconstruct the thumbs when the child is between 12 and 18 months of age, because that's kind of good age. Beyond a year, anesthetic safety is much better. But maybe for the small equal-sized duplicates, we might need to wait till the child's much larger, so that the thumbs are larger and easier to work on, and might be easier to visualize the physis and the joint surfaces.
Thank you.
Yeah, and to your point, Darryl, the longer you wait, the less the physis becomes an issue, right?
Yeah, it's a challenging, particularly that symmetrical where both elements are hypoplastic. I think it's a very difficult operation to get perfect. So look, I think we should push on with the next talk. We're sort of at 10 o'clock. So thanks very much, Darryl, for that really interesting talk. Jessica has asked me to alert everybody to the PULM Talks YouTube channel, which is where all these talks are going to be recorded and available for following up. So, which I think will be a fantastic resource as well going forward.